Well, my name is Kenneth Lukwagandason, your host, and today we'll be looking at Uganda's preparedness for the current disease outbreaks in the region. Well, the Great Lakes region is currently under attack from two diseases, Marburg and Mpox, which have left so many people concerned. Now, the situation is tougher in the DRC and in Rwanda, where a considerable number of people have already died. Now, that situation puts Uganda, which from time to time has people crisscrossing the border, on alert. Now, some people are wondering why the Ministry of Health is not very active on the two diseases, like it has been in the past about Ebola, COVID-19, in terms of public awareness and enforcing standard operating procedures. Now, this evening we'll be asking questions. These diseases that are causing havoc in the neighborhood, what is our game plan? The government has been talking about a robust capacity built over many years to handle outbreaks. What does that imply? How reliable are we in terms of budgeting for health, which is a critical matter during such times? Now, my guests this evening are two gentlemen who are involved in the health sector. Let me introduce Dr. Daniel Kyabayinze. He's the Director of Public Health at the Ministry of Health, that is the ministry here in Uganda. Good evening, and thank you very much for joining us, Dr. Kyabayinze.
Thank you, Kenneth. Glad to be here.
Also in studio, Mr. Justinian Muhwezi Katera, in-country consultant at the Global Health Advocacy Incubator. That's a US-based organization. He's a lawyer in private practice who consults at the intersection of law, health, and public policy. Good evening, and thank you very much for joining us, Mr. Katera. Well, we'll begin with you, Dr. Kyabayinze. You're in the thick of things at the Ministry of Health, but also this particular aspect is a public health matter. When you look at the outbreak of Marburg, Mpox, in the DRC mainly and Rwanda, but also we have had cases here in Uganda of Mpox, what you would like to tell the public?
Fellow Ugandans, we are at a time when we have one potential danger. We are at alert for Marburg, a hemorrhagic fever, which spreads quickly and very fatal, with a very high number of people who die when they get the disease. Also, we know that a public health emergency was declared of international concern, public health emergency of international concern for Mpox, which is also now in Uganda, but also we know that it came from the neighboring countries. This puts us at a very high active mode. Less to say, you said we're not so active, but that puts us at crossroads as a nation. We have to activate all our public health actions together. Let me start by Marburg, because that is not yet here. So we are at level 1, where we do not have any case in the country. We do have 4 levels of actions, but we are at a level where we have no cases. So the things we activate within 24 hours, 72 hours, and then 7 days. At the moment, we've now all crossed our 72-hour actions. We have alerted all the health workers in the country of the prevailing cases of a potential spillover from the neighborhood, which is Marburg. We've given them what we call a circular, a medical circular, to tell them what to prepare, when to expect, what to heighten in terms of infection, IPC, infection and protection control. And also, we've also heightened to say what stocks they must have at the moment. So we're now going through the logistics of creating an action matrix for every health worker in the country. So at the level, we are doing coordination. In the district, we are activating what we call the district health management team to start our meeting. But when we go to level 2, when we have reported a case, so we've already prepared the ground for the what we call national task force or the district task force. Now, there's a slight difference. One, you are doing your preparedness and readiness assessment. So readiness, should there be a case? Are you taking temperature? Are your point of entry monitored? They have all been activated. And in fact, this morning, I was just coming back from one of the point of entry in Ntungamo, Miramar Hills. They're all well activated. All the 6 districts along the border between Uganda and Rwanda are on alert for Marburg.
Well, you talk about Marburg. Let's look at the signs and symptoms, just very quickly, so that people can understand, just in case something comes up.
So Marburg as a disease starts as normal of the normal diseases we would expect, a febrile illness. So that's why we need to be very alert. And the disease is usually spreads when people don't know that it's in. So, for instance, the first early signs, we do have fever, which includes subjective fever. You are feeling hot as a person. There is a lot of appetite. People don't want to eat. They are withdrawn. There is fatigue, always feeling very tired. Headaches, which are persistent. Joint and muscle pains. You can get redness of eyes. So as we get to the late signs now, we start getting sore throat, painful swallowing when you are swallowing something. You can get a rash on the body. Then there is abdominal pain, and this abdominal pain usually comes with diarrhea and vomiting. Now this is very rare. When you get to the level of where the body is beginning to deteriorate and run down, then you get hiccups. I don't know how you call that in the local language, but kaskonda. Then you also get unexplained bleeding or bruising spontaneously from many parts of the body. That's kind of the end game, that the clotting factors in the body, and the body is being overwhelmed by the virus. So those are the signs and symptoms.
All right. Very quickly before I bring in Mr. Katera, we have two countries that have a tougher situation, Rwanda and DRC, in terms of Marburg and Mpox. Tell us what is at the border in terms of the Ministry of Health, because we have an entry point. We have entry points at the two borders, but there are also various entry points.
We have
but
six,
also we have the international airport.
So we have 6 crossing or designated point of entry between Uganda and Rwanda. We have in Chisoro, Bunagana, we have Chanika, we have Mirama Hills, we do have Chishansha, and there are some in between there which names I have now forgotten. But all the 6 have already been visited. We have set up, first of all, screening for febrile illnesses. We've talked to the point of entry immigration officers plus the health port activated.
So there's screening going on?
Yes, there's screening because it has never stopped. We do have thermal scanners where you pass through a health point where you are screened, you do hand sanitization, but beyond just screening, we are collecting intelligence information. People tell us, where have you been? What are the activities you've been involved in? So we are able to map our risk early enough. Because if we don't do that, people will still come and pass without us noting. But we are so alert at the moment because people know that something is going on. So we have a sample collection predisposition. We have had health workers trained and given PPE that when they're taking samples, they don't infect themselves. And then we have a rapid transfer of samples through a hub system that we can get those samples to the Central Health Laboratory or Uganda Virus Systems in Entebbe in less than 24 hours. So that's important for us to say we are prepared. And we've now also designated, like in that region, Kabale Regional Referral Hospital will have an isolation and treatment center already. And all the port of entry have a health facility where we can segregate people who we are suspicious of, because that's where we think it will hit. But we're not only looking at the borders, because people transit through buses. Our main hubs of looking out for what comes from that place will be Masaka and Mbarara, because these are cities and people have family, and transition point because these are trading hubs. So those we also have to be very alert about.
All right. Now let me come to you, Mr. Katseda. You follow closely matters happening in the health sector as a public policy analyst. You look at different things that happen. What's your reaction? What is your take on the level of preparedness our country has in terms of responding to this kind of situations, based on the experience you have?
Yeah, thank you very much again for inviting me here. And I want to thank my friend, Dr. Daniel Chawainza, for his elucidation on what we are doing as a country to prevent both Marburg and to respond also to Mpox. Well, what is my view on the level of preparedness? I think we are well prepared. We have capacity to prevent. We have capacity to detect and to respond. Now, where we come in as a sort of a civil society organization is that we ensure that the doctors, like Dr. Daniel here, have the financial resources to do the work that they need to do. And so obviously, as he describes some of the work that is required, we'll need a very serious call on the budget right now. I think they've made a call on the national budget. They've also sought donor assistance, international assistance, through Africa CDC, through the World Health Organization. And so for us, our job is really to support the Ministry of Health, to support the Emergency Operations Center, to support the Institute of Public Health to get the resources they need to respond. And we do it by pointing out a couple of things. If we don't do what we need to do now, for every dollar that is not spent on these measures, it will cost us probably 500 times more economically. So I think, for example, if we don't spend, and I'm not going to put a cost to it, but I think Doctor maybe may know a cost, may have a figure. If we don't spend what we need to spend now, then there is a risk that by December we may have a travel advisory, especially in relation to mpox. If we have a travel advisory in December, we won't have our people come for the holidays. So the diaspora loss of revenue, the loss of revenue of tourism, etc., would be huge. There would be a huge impact on our economy. Now, tourism accounts for, I think, 20% of GDP. So I think my call would be to support the Ministry of Health, to give them the financial resources they need to detect and respond to both mpox and Marburg. And we join in that effort.
Well, let's go to Chabazire. On that particular line, level of preparedness, funding is very critical. I beg your pardon, Chavayinze, Director of Public Health. How prepared are you? Have you been accorded the resources that you need to be able to prepare and respond?
No love lost in terms of mispronouncing my name. It's I also can't pronounce many people's names, so to me, I don't take any offense. As a government, it's very difficult to prepare and set aside money for something which has not yet happened. So we really need to get people who know how to talk to government to make sure that they put money aside. That way we have health insurance for our families. We're not saying we're going to fall sick, but we put money aside. We should be continuously putting money aside in a fund which is easy to activate should we have outbreaks. But we find ourselves that every time there is an outbreak, then we go into budget preparation, trying to seek for funds, and some things need reaction. Just as he's just said, what we don't spend now will be 500 times more. We need money to preposition people. We should now already have money to be on all airwaves, taking people about mpox. We should already have money to be able to track and isolate people who have mpox. We've already exceeded 26 people in the country. We are now almost in hundreds. It has now penetrated, mpox has penetrated some community. So because these are happening, now our biggest worry, what happens if it penetrated schools? So we should already have resources at our disposal. But government is government. There's a way.
You're scaring us.
No, I'm not scaring you. I'm telling you what we prepare for. In our minds, for us, we do a preparation of no regret approach. We don't want to regret that we didn't do this. So we may be overreacting, over communicating. We don't want to be sorry. Because at the end of the day, if things don't go the way we expected, we'll be held accountable. So what we're saying, this is what goes through our mind. What is the worst case scenario? So we prepare for the worst case scenario. It doesn't happen, no problem. You still clap and say, because, for instance, in 10 years, we have about 10 outbreaks. So was money preparation? Have we learned? Because we had Marburg in 2017 in Quen. There were 4 people who died, 3 confirmed. But we are able to control it in 21 days, which is the single cycle. So there was no spread from the spillover from bats to more than one community. That's the kind of responsiveness we want to have, but we need to have resources on the table.
Well, when the Director of Public Health is here to tell me, an ordinary person, the listener out there, that for the case of mpox, we have cases now spread around communities, and there is fear they could be in schools. I mean,
no, it's
scaring.
It's not scaring.
It is.
Let me tell you how mpox is being spread. It is being sexually transmitted. First of all, it came in with mothers who are coming to seek care in our country because we have a good health system along the border with Congo. They're all antenatal mothers who are pregnant come to seek care in our side of the district and walk back. We can't deny them services. Now, some of them have friends and families across the side. Some are even in the refugee. So I'm not scaring you. I'm telling you facts. So that's a definite way that there is.
So it was passed over to the doctors?
No, to the community. In fact, the initial cases in Kasese, there was no local transmission. The doctors didn't fall sick. The first 2 cases we got in July up to now, by the way, there were no local transmission until it came to people who we see have sexual networks. You can see people having multiple sex reactions or relationship with people who are on the tracks. Now, from there, we have started speaking it in Kampala, in Amur, in Mayuge. So when you begin hearing it in different places, you know that it's along the transport chains, transport routes. So the disease, and you know why am I saying square? The parents who get it may keep quiet, but they have children who go to school. So you may start up by saying one child is sick. You say this child has never left the country, but say what work does his dad do? What work does the mother do? If the mother is also evening person, the disease will come. And it affects the private parts. They get sores. They don't want to tell. Until we see blisters on the faces, people can be moving with the disease quietly. So that I'm not saying we are rumor mongering, war mongering, or trying to scare the Ugandans. We are telling them, change your behavior. Otherwise, you'll go and have an interaction with already an infected person, and you'll bring your disease home to your own family. So the way we've been talking about HIV, have one sexual partner, I think we are going to even use some of those same messages. Have one sure, faithful contact all your life.
Mr. Katira, now, you're the one who brought this situation about funding and the link it has in terms of the country responding to such outbreaks. There's been a major concern. Even when you go to Parliament, you'll hear members of Parliament talking about it. You people in civil society, they have reliance on donor support for our public health responses. You heard Dr. Chabayinze there talking about the need to have a fund somewhere. Our constitution actually talks about a contingency fund. In terms of analysis, in terms of your interest in this matter, are we prepared? Is the government responsive?
Well, yes, thank you. And just to point out that the Global Health Advocacy Incubator, which is a US-based organization for which I consult, identified this need for budget preparedness. And for the first time ever, the government of Uganda committed 57.8 billion in funding for pandemic preparedness and response in this financial year. That's $15 million. It has never happened. 57.8 billion is a huge, huge milestone. And in East, Central, and Southern Africa, we have the highest amount of money dedicated to pandemic preparedness and response. So that's a huge investment, domestic investment. There's something else which has happened, of course, which is that this U.S. Center for Disease Control has not been able to continue supporting some of our efforts on pandemic preparedness. And that has required us to use more of our own government money than depend on unsustainable donor funding. And that is the right way to do things. So we had support from the Health Committee, Dr. Yume Charles at the time. We had support from the Budget Committee. Parliament approved the 57.8 billion. And now we're in the process of developing annual operating plans to absorb that money. So yes, we are investing in health security in Uganda.
All right, Spectrum on Radio 1 FM 90. Our topic of discussion today, we are looking at Uganda's preparedness for the current disease outbreak in the region. We have a challenge of Marburg and Mpox, which is going on mainly in the DRC and Rwanda. And my guest this evening, Dr. Daniel Chabayinze, Director of Public Health at the Ministry of Health, and Mr. Justinian Muhwezi Katera, in-country consultant at Global Health Advocacy Incubator, trying to make sense of the situation. But also share with us, use our WhatsApp line, which is 0703 090 What's your experience? What do we need to do? Now, Dr. Chabayinze, let's look at our health infrastructure in terms of preparedness. There was a lot of money, we actually told, from our national budget, but also from donors and even in terms of borrowing, as we responded to to Ebola and COVID-19. And the minister has been actually telling us that because of those two situations, we have built adequate capacity in terms of the health infrastructure. What exactly does that mean in terms of dealing with these kind of challenges that we're looking at?
Thank you. I do not have the figures off my head, but let me just paint a scenario. When we got, by the way, we don't have Marburg in our country. That's very clear. I need to make that known to the Ugandans. We do not have any cases in our country. We're just preparing in the eventuality. In unfortunate circumstance that should this happen, we prepare. It's like when they say there's life jacket, should there be a need to use, we fly knowing that's happening, and you have to have that preparation. So, for instance, when we had Ebola, the donors pledged almost $80 million because we planned for the worst case scenario. But at the end of 91 days, Ebola had come to an end. Transmission had been cut. So the people who had prepared the money did not even spend half the money. And we hoped that the donor money which they had pledged would be transformed into infrastructure development and preparedness. Unfortunately, we are not able to see the visibility of what the rest of the money, those who were holding on to it, transformed it to. They did some capacity building, but they are not infrastructure developments that we hoped to live in place. So our plea is, if donors want to support us, and they do support us, they can also include own budget, because there we have the flexibility to appropriate through Parliament. When they do it off budget, then they give it to their implementing partners, who also have other regulations how to implement and use the money. So it's still not sustainable, but it does not leave a health system strengthened component, which we want. However, when we had COVID-19, we saw how Ugandans rallied their money. They collected a lot of money. You gave it to government. We bought over 300 surveillance vehicles, which still stand today. That was so remarkable. Unfortunately, some people are beginning to abuse the cars by using them for non-health related issues. But it shows that the people in Uganda know when there is need to raise resources, them as citizenry, they can do it. We also built infrastructure in terms of oxygen, infrastructure piped. Now we are also making sure we can manage PPEs. We also strengthened our point of entry health ports during that time. So some things after the outbreaks of COVID, Ebola, we've seen certain things happening. We also now put up surveillance to following up survivors. You know, when you've survived Ebola, there are chances that your body still holds some viruses into your body, and it takes long to stop shedding off. So those people we've continued to follow even 1.5 years later, to make sure nobody can transmit diseases to their children or to their spouses through the seminal fluids or during the act of intimacy. So there are things we keep doing. Now we already have isolation centers in major hospitals. Regional Referral Hospital, you saw what we put in Mulago, in Tebe. So these are things which remain after an outbreak and a response. Now Uganda can be a training center for the region, because we were able to address major outbreaks in a record time. And our people have remained the technical staff and technical advisors in the region should there things happen. In terms of what money we now need, I think when we have a chance to interact with our accounts holders and the parliamentarians and the ministers, I think they can give us. But for us, we have operational budgets. We have national plans for which we shall be following. We have a multi-sectoral approach. We have active surveillance. As I speak now, our commissioner, integrated epidemic surveillance, is in Chisoro, making sure he's manding all those border points. They are ready. So I think we are on the right path. But financing needs to be thought through very well, because I don't know whether we are the best people to advocate for our own finances. Some people have a notion that when we tell them we need money, they say, oh, they're looking for money to eat. And then when things don't happen, say, hey, why didn't you do what you do? Money is a motivator, but it's also a facilitator. We need money on the table. I'm not going to bang the table. We need money on this in our accounts. Yes.
Well, Mr. Katera, money, money, money. When we return from the break, I would want to hear from you in terms of advice, how we can actually sustain funding. There is a threshold, a declaration which was made in Abuja some time back in terms of budgeting 15% to the health sector. I don't know how far we are now, but how can we actually make health sector a serious issue? Because everyone in this country would require some treatment in case they have a problem, but it seems we are not actually getting there. What do we need to do as a country to respond to that challenge? Stay tuned to Radio 1 FM 90. We're going for a break now. When we return, Spectrum will continue with our topic, looking at Uganda's preparedness for the current disease outbreaks in the region. Thank you so much for staying with us on Spectrum, live on Radio 1 FM 90. Today we are looking at Uganda's preparedness to deal with the current disease outbreaks in the region, where we have a situation of Marburg and Mpox in the DRC, but also Rwanda. We closely share a border with them, so people are always crossing in and out. In studio, Dr. Daniel Kyabayinze, Director of Public Health at the Ministry of Health, and Mr. Justinian Muhwezi Katera, in-country consultant and Global Health Advocacy Incubator, a US-based organization. He's also a lawyer who consults at the intersection of law, health, and public policy. We already heard from Dr. Kyabayinze, who tells us that efforts have been made to ensure that there's screening of all people who are moving inside the country from the two countries, that's Rwanda and the DRC, but also the health infrastructure in the neighboring places have actually been put on alert to respond to any situation should it arise. Now, Mr. Katera, how would you advise us to deal with the issue of funding? Because that seems to be a critical issue. Like I already told you, it seems the biggest percentage of our budget, we keep on getting funding from the donors. How can we, what kind of formula would you advise so that the health sector can also become a major priority, because we all need it?
Okay, I wish I had an easy answer to that one. You mentioned 15% of the budget should be spent on health. I think we've been averaging about 8% over the last 3-4 years, 5 years, or even 6. Of course, let me speak from my experience in the last 1 year trying to get the money for pandemic preparedness. I think one of the big things that we've kind of recognized is that, like our colleague Daniel, they are doctors, and I think they are not necessarily political or legal in nature, and so perhaps there is a need for the medical profession to be a lot more involved in the advocacy effort in order to gain the funding that they need. It's a political process, by the way, funding. And maybe doctors don't think that it's their natural place to do these things.
But we have doctors in places like Parliament, but even in civil society.
We do, yes. But also remember that you know when people say 15%, it was an ideal. I think we've heard from government that 15% is achieved only that if you look at the Ministry of Health budget, it would be 8%. But health is in everything, in education, in other sectors. So, and I'm not going to defend government here.
Some people have said that's a strategy to run away from from the main issue, which is the 15%.
Yes, I mean, in a resource-constrained setting, I think doing a number is useful. It's a target, but we haven't reached that target yet. I think we'll keep pushing. You know, if we could do 10% next year and we move up towards 15%. The biggest investment in any country is health and education. And so the need for the 15% to be achieved is there.
And
I think we need to have
no country has reached 15%.
No country.
No country has reached 15%.
No.
But it's an ideal situation. I think more advocates pushing for the 15% allocation would be great. On the other hand, there has to be greater and better accountability for the funds that are used so that it doesn't frustrate the advocacy effort if there is anything mentioned about accountability issues.
Now, one of the interventions that the government is looking at in terms of mobilizing resources is the National Insurance Scheme, which is unfortunately not yet there. In your opinion, having seen what happens in other countries, how helpful would it be in terms of providing the capacity that we need when you look at the resource constraints that we have?
The National Health Insurance Scheme is an absolutely good idea. It's been costed. It would help to transfer resources away from the consolidated fund to these funds that assist people to access medicine and access healthcare. And so I think one of the big things is obviously to push for it to be implemented, subject to the controls and the concerns that have been raised about how it would actually be operationalized. We are learning lessons from Kenya, for example, and from other countries about how best that system should be run. And as soon as we have those lessons learned, we hope that Parliament will move swiftly to pass the law and to implement it.
Well, Dr. Chabainze, how helpful would the National Insurance Scheme be in terms of helping you to realize the capacity required?
You know what National Insurance Scheme will do is pooling money to even out resources for everybody. It will it will help us look at all our service packages to be equitable for everybody. Actually, there is community insurance happening in so many parts of the country where they have their community schemes, they pull their money together, they look after them themselves. And the Ministry of Health has already done its part in terms of the National Health Bill. We've put all the paperwork and it's now at Cabinet. So if any of you is at Cabinet, I'm not requesting, I'm just telling you that that's where we are at the moment. So if Cabinet gives us a go-ahead, I think we will be good to go. However, we are also, as Katera has said, we are following what is happening, particularly in Ghana and Kenya. All the assumptions we had seem not to be holding water in those two countries at the moment. So whereas we want it today, but we are also saying maybe it's good that we are also learning and hearing what is happening in those countries. Government is actually ending up putting money in the scheme itself. Yet it's supposed to be that this money is going to be helping to sustain. But the most sustainable way of looking after ourselves as a country is to have an insurance so that we don't expect government to meet all our health bills. Government will only go so far until they are constrained because they have other things, infrastructure, security, social services, education. So for us who take our health to be more important, we should also be pressing that this is the most sustainable way. Let's put money in a pooled way. Those who are healthy, because our population is very young. The possibility of people falling sick so soon will not be so huge. So the majority of the people will not actually be consuming the services. So it's not going to be very expensive for our nation compared to countries which have a little older populations. So I think we are a good opportunity to start now in terms of having this very youthful and relatively very healthy population.
What kind of model are we following? How will it be? We have heard about different models when it comes to national health insurance schemes, and we hear contributory, we hear different kind of models.
So a proposal has been made to be contributory by everybody working, and there will be different tiers, but everybody, even the community, nobody will be spared from making contribution. Now, I cannot divulge the details of that contributory because it has to be agreed on. But for us, we want everybody to contribute. If you are in a community, in a home of 7 people, and we tell you for every person in your home, contribute your 5,000. If you are in another level, then we say at your level of earning, you contribute 20,000. And then there will be different tiers. That's the model I think we are proposing. But I mean, there are many models, and the people who are experts, our planners, commissioner for planners, can come and give details. But for us, that's what we've been listening to and thinking that will what happen. Then the money will be able to be plowed back in making health services better. Maybe we shall pay our health workers better. Maybe the medicines will be more available. Maybe even the preventive arm will be more strong, that we shall be promoting prevention and immunization and disease prevention and control, even elimination, so that we consume less of the curative services.
Mr. Katera, your take on this model, do you think it's the kind of model that can work in Uganda? But also, you talked about the Kenyan lessons that we're taking from Kenya. What is it that we're doing that we're trying to learn from them?
Well, national health insurance schemes everywhere around the world face challenges. The national health system in the United Kingdom is based on paying a proportion of national income. We have Obamacare in the United States, and there's always a lot of work to be done because it's very challenging. Kenya has faced challenges with that, and Ghana. So I think as we go forward, we are going to be very cognizant of how the system can be, one, abused, and two, if you have a population of income earners, which is still very low compared to the rest of the population, then you've got to also think, how does that financial model really sustain itself? I don't know how many people in actual earned employment. I don't know if it's 10% of the population. So would that 10% contribute and cover the remaining 90%? Those are financial models that need to be looked at carefully. But as a principle, it's a good thing. I think we still need to work out some of the technical detail to see how we can sustain it. Otherwise, if it fails, then the government comes in to step in. And then that means the scheme in itself has not really achieved what it intended to achieve. It's easier when you have, say, a 60% population in formal employment, paying taxes and then paying for the health insurance scheme. But if you have a different model, then it might also be challenged, like was the case in Kenya and in Ghana. But it has worked in Rwanda. So I think we can compare all these models and see what best works for us.
All right. It's that time when we get feedback from members of the public, people who are listening to us, and we have comments already coming in via the WhatsApp line. We begin with Eric. Eric says the Ministry of Health already receives considerable amount of money, but the biggest problem we have is corruption. Resources are not being properly utilized, and can the Director of Public Health confirm to us that even when we contribute to the national health insurance, the funds will be put to proper use? Let's begin from there. You earlier on talked about how people rush to conclude that you're asking for more money so that you can actually have it eaten. And this listener seems to suggest that the ministry is also not so clean when it comes to issues of corruption.
I wonder how we are measuring corruption. And I do not want to say that my colleagues are angels. Neither do I want to say corruption is in the Ministry of Health. Unfortunately, we are a service delivery unit. All the people who come to us are desperately looking for health. So any hint of them spending or not getting the service they deserve or they should get has ripple effects. It stays on their heart. First of all, we are the entry point into life, but we are also the exit out of life. So some people come to rejoice receiving babies, others exit taking their loved ones for burial. So we are not looked at as a normal service provider. We're not like education. When you go to school, when you're happy, when you have no school fees, you don't go. It has a choice. But for us, everybody must get services. National insurance scheme, money is not going to come to Ministry of Health. We are not the insurance agency. So because we've not had a chance to educate people about what the models will be, we're not going to receive your money. We are going to be paid for services we give from where you'll be contributing your money, and the people will be accounting to you because they received money from you. So those are two different things. The other challenge about insurance company, first of all, this country, it's very difficult to set the basic minimum. We don't have a minimum wage. So we don't know how everybody much earns. So the people we think don't earn much earn a lot of money. And those we think earn a lot are all running in debt. So we can't have a final model unless everything is documented. We go into the digital age. Everybody can account. Everybody does their tax returns. All money is documented through buying and purchasing, but I can get my things and sell here just to your neighbors below here than in the market. And nobody knows how much I'll earn. I'll put it on my mobile phone and go. So we don't know whether you are capable of paying 5,000 or 20,000. But even a single surgery, if border caused you an injury and you broke your leg, the minimum money the government spends on you is 3 million. Minimum. But can you imagine pulling 3 million out of the 60,000 accidents we get in Kampala due to border? So the preventing arm will be a better prevention, will be a better approach for us. Let's have everybody listen to authority, follow the regulations, prevent all these accidents, eliminate diseases like malaria. Then our expenditure needs for health will not be so catastrophic because we transfer that back to government. And when we don't get the service we want, then we start demonizing the government for not being able to give everybody the kind of resource they need. If we got clean water, then some of the communicable diseases will go down. If people slept well and have good housing, if people eat well, other than the so much fried chapati and chips, and then we all get all kinds of malnutrition challenges, then I think we'll move towards a healthier community. And then the need for spending on health will actually go less. If we plan our cities with green parks where people can walk safely and jog safely and have activities, all those things all impact. As Katera said, health is not just curative or services, it's everybody's business. That's how we should see it. So Eric, just to let you know, we're not planning to be corrupt. We do not say we are not corrupt. We apologize where our colleagues or us have been corrupt, but we are working towards a journey of being a corrupt-free community.
Well, Spectrum on Radio 1 FM 90. Let's hear from you, Mr. Katera, on this issue of proper utilization of funds. We are in an era where donors are telling us that, look, we are likely to pull out money because of the challenges we are facing home. Therefore, there is need for sustainable utilization of resources. If you look at the public, if you look at the health sector, how are we doing in terms of that? What advice would you give them to ensure that the resources they get, the meager resources they get, according to the lack that has been explained, are properly utilized?
Well, I don't know that I can necessarily advise on prioritization within the health sector.
What would be the priorities?
Well, having had a long discussion once with the Health Committee of Parliament, it's very difficult to say put money here and not in Cancer Institute, because you end up making very difficult choices. Do you put money in blood transfusion, less in ambulances? Do you put more in malaria than in TB? Those are very difficult choices, I think. But as a guiding principle generally, as Dr. Daniel has mentioned, if we invest more in prevention and the public health measures, then you would avoid the curative medicine at the end. So if we dealt with diet, for example, perhaps we would also avoid the cancers at the end. And so I think primary health care is a necessary place to start the investment in. In relation to donors, I think that it becomes a bit of a moral hazard. It's very difficult to stay addicted to donor aid in health. It is necessary, obviously, and we welcome international assistance for health. But I think that at some stage it would have been necessary for us to take greater responsibility for our own health needs. And we have had to do it now, given the cuts in donor assistance. So we welcome the additional investment by government in the health sector, and we request that more is placed in primary health care, more is placed in prevention than in curative services. That is a very broad guiding principle.
All right, we have a comment coming in from Patrick Kibet, who is listening in from Bududa district. It says, good evening, moderator and the guest. The biggest challenge we have in this country is budget exaggeration. When such outbreaks occur, I would agree with Doctor that a contingency fund be set aside to cater for such outbreaks, but the same people in the ministry will just end up abusing it. Corruption has really eaten up all these ministries.
Bududa. So corruption. We must all fight corruption.
This listener suggests that in times of crisis like this, numbers work up numbers very quickly, put in more than what is needed, and no proper accountability.
You know what they think, that we work up numbers up. As I said, we do a no regret approach. We plan for the worst case scenario and we work quickly to end the disease. If we ended Ebola in 91 days, everybody was predicting we are going to have 6 months. In West Africa, it took 2 years. So, but everybody is entitled to what they're feeling. If they feel the system is corrupt, we have opened up feedback from clients. We do have a number. When you go to a hospital, there is a RQ code you can scan and say what services you received, how you were treated, and if you have comment. So we were going to use this opportunity for you to report who was corrupt. We are going to mandate our health workers to have their name tags and put on uniform, because there are people who charge and take money who are actually fellow sick or attendants in the hospital. They are middlemen and brokers of services. Say doctor has asked for this, but he has never asked. So once we completely do a system check, we have put CCTV cameras in our hospitals. We are going to be able to see what is happening. So please come out and report. If you have a number or a name to give on this kind of radio show, we take details and we investigate. Also, that will help us to become more accountable. So we'll fight corruption together, but you cannot wait to say corruption on a radio talk show and you are in a hospital, you are not given service, and you didn't even report. Now, we are going to give these numbers. We have our toll-free numbers, call centers. Please call and give us some details. We are more than willing to handle. And we have many people waiting to take up the positions. So if those who are in the system can't do a proper job, they're not transparent, lack of integrity, then they will be shifted out and others take up the responsibility and the jobs.
Almost the same point coming in from Samuel, who is listening in from Tinda. He says we need to take a strong stand on corruption. We need confidence in the fight against corruption. Well, beyond the QR code that you talked about, what other measures are in place at the Ministry of Health to ensure proper utilization of resources?
First of all,
mainly we have a problem with corruption in procurement and so many other places, if you look at what happens in our country.
So first of all, let me first debunk the corruption tendency. Some people don't get services and they call it corruption when they are charged, because government gives free services. So every Ugandans, for instance, 12 million cases of malaria we get every year. So we have 12 million opportunities to be reported as corruption, because the sheer volume of people we treat. Secondly, what have we put in measures? There are numbers and saying this is a free service. If you are charged, call. Many people have phones. If you don't give us feedback, we will not be able to know what to address. Secondly, we are now using digital tools to pay. When you go to Women's Hospital in Mulago, you are registered, but you pay through a platform. You don't even have to pay through cash. And everybody who pays now gets a receipt, so that there are no off-site payments. In terms of holding our colleagues accountable, we have biometric check-in, duty rosters. If you reported so-and-so in this unit, we just go back to the duty roster on the wall, which are well displayed, and say, these are the people we had on that ward. Who of the people can you identify? We also have the health monitoring unit. It's holding us with the health workers accountable. And I think you've seen what is going on. We are being prosecuted. We are being told to come to task. How come blood is in your private hospital? How come in terms of working in that day you are on the duty roster in the main hospital, we are finding in your clinic? So we close the clinic or we transfer you where the clinic is not. But there are many measures to make sure, first of all, us, we are dealing with a trust. People come to us because they trust us to do a good service. If we don't do a good service, they are going to start going back to the shrines. They are going to go back to birth attendants, TBAs, village attendants, because we are failing. But when people start coming and demanding for our service, I think there's something we are doing right. We only have to clean out our name of being corrupt. I think we should do a barometer measure for corruption, but that won't save the day. We're not trying to justify any corruption. Any corruption is corruption. And for us, when in the health system we are corrupt, somebody can die. It's irreversible. So we should have zero tolerance to corruption in the health system.
You agree, Mr. Katera?
About zero tolerance? Of course I agree, but I think the question is, corruption, it's a very difficult question to answer, but this is what I think, and we've had this discussion before. We need to move government accountability online. I think that there's been a model that has been tested. You have e-government services. You can see a procurement process from the beginning, right? This is the bid, these are the companies, this is what they are going to pay for, and this is the service that we expect. We also have AI tools that are changing the face of accounting in government. We will get rid of human intentionality to have kickbacks. So I think in the next 5 or 10 years, we are going to have a system run by artificial intelligence that will take the finance function to a different level. And I think that, for me, I think is the easiest solution, the use of technology to get rid of accountability errors.
All right, I'll give you an opportunity to give your closing remarks, Dr. Chaba Yinze, as we come to the end of this show.
I want to take this opportunity to invite all the people in Bugisu and Bukedi region that tomorrow we are launching polio vaccination in 49 districts. We are going to come door to door to vaccinate all the people in that region because we had a confirmed environmental circulating polio, yet we had gotten elimination certificate. So we are going to do a round. So I'm encouraging all Ugandans to embrace these activities.
Mr. Kater, your closing remarks.
Well, first of all, I want to appreciate the efforts of the medical community, the public health professionals who've been at the forefront of dealing with these epidemics. Again, I think we have a duty to seek investment in personal protective equipment, to assist them, because there's nothing worse than having a medical doctor, a nurse, or any other public health professional dying as a result of exposure to these infections.
All right.
Thank you very much again for inviting us.
All right, with that, we come to the end of Spectrum. Let me thank you, gentlemen, for making time to be with us, but also the listeners for tuning in and contributing to this discussion. Tomorrow, same time, Spectrum will be on air with another topic. But right now, I hand you over to the news desk with the news for the news in English with Miss Josephine Dagano. Thereafter, continue with the great songs and great memories with BB Junior bringing you the Soul Train.